disease of the young. It is not a disease of the elderly, okay? Like osteoarthritis. So it is a disease of the young, 25 to 55 years of age. Now, what exactly happens in rheumatoid arthritis? So obviously it is an immune mediated process. There are antibodies acting against the joint, acting against the joint lining, acting against the cartilages around the joints, and thus leading to inflammation. And because it is an erosive arthritis, the healing leads to deformity. So it is one arthritis that can make people end up with very bad deformities. So this is one arthritis that need to be diagnosed in one glance, and that need to be treated aggressively initially only. Otherwise, your patient is going to end up with deformities, right? So it is one important arthritis, and hence it takes up space in your question paper too. So let's talk about this. So what happens in a normal synovial fluid? In a normal synovial fluid, there are two types of synoviocytes, type A and type B. The type A synoviocytes, that are the synovial cells, as the name suggests, are derived from macrophages, and the type B synoviocytes are derived from fibroblasts. Okay, so macrophages derived and fibroblasts derived. A normal synovial fluid contains elements like lubricin and hyaluronin. A normal synovial fluid is a thixotropic fluid. It's a thixotropic fluid. Thixotropic fluid means that the viscosity of the fluid decreases with shear or stress or joint friction in a case of a joint, right? So it reduces, the viscosity of the fluid reduces. Now what happens in rheumatoid arthritis? There is an inflammation. So approximately 5,000 to 50,000 WBCs in synovial fluid are there per microliter or mm cube. In osteoarthritis, this number is less than 2,000. In osteoarthritis, this WBC number is less than 2,000 because it is a non-inflammatory arthritis. In rheumatoid arthritis, since it is an inflammatory arthritis, this number is high. Secondly, it leads to erosions in the joint. When it leads to erosions, it leads to problems. When it leads to erosions, that also leads to, when they become chronic, they lead to pannus formation. Whenever there is an erosion, the body reacts, and in that reaction, something heals, something doesn't heal, but things get added up. And when things get added up in the joint, they lead to something known as a pannus. So it leads to a pannus formation, right? And then these are mostly the self-reactive T cells that act on the joint and lead to erosion. Okay, so it is an inflammatory arthritis with a high WBC count in the synovial fluid, and this is how it leads to joint involvement. Now, what are the main features on an X-ray of a joint in an RA patient? What are the features on X-ray? Now, to remember these features, I have a mnemonic for you that I also used during my entrance exam preparation. The mnemonic goes like PSES. PSES. Okay, so PSES. Right. So P stands for periarticular osteopenia. Periarticular osteopenia. S stands for joint space. Joint space loss. Joint space loss. E stands for erosion. Subchondral erosion. Subchondral erosion. This is asked in the radiology. Okay, so please remember this. And then there is subluxation and ankylosis. Subluxation and ankylosis. Now, if we talk about ankylosing spondylitis, there also joint space, something happens to the joint space, but there is a pseudo widening of the joint space. But in rheumatoid arthritis, there is a loss of the joint space. So try to remember that. So periarticular osteopenia, joint space loss, erosions, and subluxation and ankylosis are features on an X-ray in a rheumatoid arthritis patient. Rheumatoid arthritis, synovial fluid 5,000 to 50,000 WBCs per microliter, leads to erosions, and when it becomes chronic, it leads to pannus formation. It is a disease of the young and it is a systemic illness. This is all you need to remember right now. Okay, and now we'll talk about the clinical features of rheumatoid arthritis, then we'll talk about the treatment of rheumatoid arthritis. Okay, I hope we are all clear on the pathogenesis or why all of this is happening. So, if we talk about joints, And then we'll talk about the extra articular features in rheumatoid arthritis, extra articular features. If we talk about joints, the most common thing that is asked in exam are the deformities in RA, right? So the deformities become very, very important. Now, one thing is that when only one joint is involved, we call it monoarticular. When less than or equal to four joints are involved, we call it oligoarticular disease. And when more than five joints are involved, we call it polyarticular disease, polyarticular involvement, polyarticular involvement. So mono, oligo, and poly. Right now, what are the joints that are mainly involved? If this is a hand, pardon my drawing again. If, oh, wait, this is too funny. I'll try again. If this is a thumb, finger, one, two, three, and four. Sorry, students. Okay, so the mainly involved joints are wrist, MCP, these joints, and then PIP. Okay, so wrist, MCP, and PIP joints. Now, what are the deformities that happen? So these are the deformities. One is a swan neck deformity. One is a swan neck deformity. Second is a boutonniere deformity. Then there is, this is the ulnar subluxation. Okay, it is also known as this Z line deformity. And then these are the rheumatoid nodules. These are the rheumatoid nodules. Let me take this, add this picture over here, and let's start. Give me 1 minute. I will add the picture and I'll tell you how to remember all these deformities. Right. Right. So these are the deformities. Now, swan neck and boutonniere, swan neck deformity and boutonniere deformity, right? How do you remember this? I remember it with the mnemonic HSP, which means that hyperextension, better listen to this very carefully, hyperextension of PIP joint happens in swan neck deformity, happens in swan neck deformity. So now if I talk about, so if you can see the PIP joint, there is a hyper extension and then there's a flexion at the DIP, while in boutonniere deformity there is a flexion at the PIP joint and hyper extension at the DIP joint. So if you really want to remember this, I'll tell you. So swan neck and boutonniere, right? So hyper extension and flexion. So PIP, DIP, DIP and PIP, right? Now we know, we will remember only one thing, H, S and P. H, S, P. Hyperextension of PIP joint will be there in swan neck. Rest of the boxes you can fill by yourself. You are smart enough to do that, right? So please remember HSP to remember which deformity is which one. Try to remember these figures. This is a swan neck deformity. This is boutonniere deformity. Now, this is something that is also known as a Z-line deformity. A Z-line deformity. Now, what is a Z-line deformity? A Z-line deformity is when there is subluxation of the first MCP joint. There is subluxation of the first MCP joint with flexion of the first IP joint. With flexion of the first IP joint. This is a Z-line deformity. Actually, these hands have many deformities in them, right? Many deformities. And this also shows a swan neck deformity, right? So that is there. So Z-line deformity is also there. So this is Z-line deformity. Z-line deformity is subluxation of first MCP joint with flexion of the first IP joint. Then there is something known as a piano key movement. There is something known as a piano key movement. Piano key movement happens because of subluxation of the ulnar styloid process, subluxation. So when the ulnar styloid process, this is my ulnar styloid process, when this gets subluxated, whenever I move my fingers, the styloid process is moving on its own, like a piano key. So we call it a piano key movement. So subluxation of distal ulna or the ulnar styloid. Right? If we talk about so these are the nodules, right? In the arm or the forearm, they can be nodules. So these are rheumatoid nodules. What are these? These are rheumatoid nodules. This is a trigger finger. What is it? It is a trigger finger. So let me just add this for you. It is a trigger finger, also known as a mallet finger, right? So this is a trigger finger, and these are the Botonian deformity, flexion, hyperextension, and flexion. Okay, so Botonian and sonic deformity. Then if we talk about feet, so there is flat feet, which is known as a wind sweep deformity. Wind sweep deformity. Flat feet, also known as wind sweep deformity. If we talk about the spine, there is an atlantoaxial dislocation. Atlantoaxial dislocation of C1 on C2. C1 on C2. So these are the main things. One, we forgot one important one, and that is the flexor tendon tenosynovitis, which can involve the thumb, which can involve the finger, so leading to a trigger finger. We talked about trigger finger, right? So these are the deformities that can happen with rheumatoid arthritis. Now we'll talk about extra-articular. So try to remember the features, the clinical features of the clinical features involved in rheumatoid. The clinical features involved in rheumatoid arthritis involving the joints. And also try to remember the extra-articular manifestation. They are also very important. So now we know what are the X-ray findings. The mnemonic for that is PSES. Now we know what are the features that we can find in joints or deformities that can happen. So these are two important questions. One is radiological findings and second is the deformities, right? Then extra-articular features of RA, extra-articular features of rheumatoid arthritis. Let's talk about this. Now, what is the percentage of involvement of extra-articular? Is approximately 40% patients have extra-articular manifestations. So these are very important. If we talk head to toe, if we talk about head to toe, if I make this person here, right? If I make this person here, then head to toe, first is CNS vasculitis, important one. Second, if we talk about eyes, then uveitis is not a feature. Sicca can be there, scleritis can be there, episcleritis can be there. Sicca and uveitis is not a feature of RA, not a clinical feature of RA. Remember, this is important. Okay, so Sicca can be there. Then, if we talk about cervical, then there can be a cervical myelopathy. There can be a CV junction abnormality, If we talk about skin, then there can be subcutaneous nodules. Of course, the patient will have something to do with the joints. Usually the small joints are involved. Usually there is a polyarticular involvement of small joints in rheumatoid arthritis. So joints will be involved. There is a morning stiffness that stays for more than 1 hour when there is a joint involvement. If we talk about lungs, then ILD, NSIP, non-specific interstitial pneumonitis, is a feature of RA, and it is something that has a poor prognosis and 10% mortality. 10% mortality. Right? If we talk about heart, then pericarditis. If we talk about lung, then again Kaplan syndrome. Try to remember these two syndromes. So Kaplan syndrome is RA plus pneumoconiosis. And I have not told you about the common features of RA, that there is a morning stiffness, there is joint swelling, and all of that. Acute RA. I think you already know that, right? So RA plus pneumoconiosis. The second syndrome is Felty syndrome. Felty syndrome is a triad of RA, splenomegaly, and neutropenia. A triad of RA, splenomegaly, and neutropenia. Then there is mononeuritis multiplex. Then there is mononeuritis multiplex. Then hematological involvement, normocytic, normochromic anemia. Right? So all of these are features of extra-articular features of RA. One important thing, it increases 2 to 4 times risk increases of lymphoma, and mainly the diffuse large B cell lymphoma. Oh, sorry, not B cell. It is the T cell disorder. So diffuse large cell lymphoma. We only say diffuse DLCL, diffuse large cell lymphoma. In kidneys, there is involvement of glomeruli, and it leads to membranous glomerulopathy. Membranous glomerulopathy. RA is also a risk